Hey everybody, welcome back to Spot Check again. We're going to go through these genoderms some more, and we're going to go into photosensitivity. Big shout out to the student, Dr. Ashbaugh and Jacoby here for putting together the PowerPoint. Without them, it's not possible. So give them a thank you down below in the comments. Got a few things we're going to go through. Some high yield stuff, actually. All right, moving on to Bloom syndrome here. Bloom syndrome here is an inherited autosomal recessive condition in the mutated gene RECQL3. RECQL3 encodes for a DNA helicase, which interferes when mutated with DNA replication and repair. Therefore, you're going to get sister chromatin exchanges as well as chromosomal breaks, gaps, and rearrangements. So, this mutation, the mutation of a DNA helicase, is also shared by Rothman-Thompson, and it's also shared by Werner syndrome, which I can't remember if we went over or not. But it's shared by those two disorders. Werner is not talked about in this PowerPoint, but Rothman-Thompson is, so stay tuned for that. And this mutation, you're going to see specifically with RECQL3, you're going to see quadraradial configurations of lymphocytic chromosomes, and that's pathognomonic. Now, the condition will be present for the first few months of life, so it's going to be pretty quick to notice something's wrong. Pretty high, dense incidence in the Ashkenazi Jew and Eastern European population, but overall very scarcely reported. Prenatal diagnosis is now made with DNA analysis, so there's no need for doing anything exciting or special with that. And there's the example of that chromosomal structure that's pathognomonic. Skin findings, you're going to get photodistributed erythema with telangiectasias and a butterfly distribution. Cheilitis and cafe au lait macules might also be found. They have a unique facies that will overlap with some of these disorders, but at least try to make a, understanding of those. So, long, narrow face with prominent nose, malar hypoplasia, small mandible, short stature. You could also see, what's key for this one, decreased IgA and IgM, recurrent respiratory and GI infections, and that's due to the IgA decrease. The IgA decrease, IgA is the mucosal antibodies. So those are mucosal membranes, and you're not protecting them as well. Neoplasia is also noted in this disorder at a low rate, but still positive and still prominent. Hypogonadism and infertility is also noted. Here's a good example on the right of a photo of somebody with this condition, with Bloom syndrome. Notice basically the erythema and the telangiectasias, the narrow jaw and chin, facies. That's pretty much the key there. Referrals are going to go where the sequelae are, so that includes infectious disease, hem-onc, and endo. Rothman-Thompson here. Rothman-Thompson, also known as poikiloderma congenitale, is an AR condition that is in the mutation for the RECQL4 gene, also in the DNA repair helicase family like Bloom. Poikiloderma congenitale gives you the clues is what you're going to find, so use that. Presents pretty early on as well. Here you're going to have erythema, edema in the face, as well as red-brown reticulated patches associated with atrophy, hypopigmentation, telangiectasias on the face buttocks is key, and extensor extremities. So they can get this pattern everywhere, especially in areas that aren't necessarily prominent to the sun, which includes the buttocks. Acral verrucous keratoses are also prevalent and happen, around puberty or after, and these can actually lead to squamous cell. In this disorder, and not necessarily in Bloom, you have alopecia of the scalp, eyebrows, eyelashes. You can see dystrophic nails in a small proportion. They have a musculoskeletal finding more along the lines of small hands and feet, hypoplastic or absent thumbs. And other skeletal abnormalities. They'll have juvenile cataracts, which is actually somewhat prominent in this disorder. Hypogonadism can happen, dental dysplasia, and rare but prominent osteosarcoma and other neoplastic findings. So, management here, you're going to have to go, like I said, follow the sequelae. So in this one, ophthalmologists are going to be involved, as well as orthopedists, and in addition, endocrinologists and oncologists as well. And these guys also have a pretty normal lifespan. I also forgot to mention that the Bloom syndrome typically lives to about the third decade, and if they get taken out, it is because of the cancer risk in the later life or infection risk in the early life. Cockayne syndrome here. Autosomal recessive condition. In the Cockayne syndrome group, there's A and B, and these link to a certain excision repair gene or protein. So ERCC8 and A, so it kind of fits a little bit 8A. And then Cockayne syndrome B is ERCC6. These mutations impair DNA repair in active genes. The key is active genes, which renders the patient hypersensitive to UV light. So this is a rare condition. Usually CSB takes the predominance to the lion's share, if you will, of Cockayne syndrome, but CSA is also documented, so don't count that out. Blood serum you can observe actually UV irradiated cells with a decrease in DNA and RNA synthesis, and CT will show you a calcification in cortical atrophy. So, why is this important? Why is it talking about active genes and stuff? Well, the kicker here and where you're going to get questions is this right here, okay? And I'm gonna give it to you in the the Genoderms for Dummies, hooked on phonics type level explanation here, because that's what it took for me to understand it. So, you know that UVB causes pyrimidine dimers. You know that because you're most likely either in medical school or in a residency of some sort. So you know that to some degree. And we know that enough of the pyrimidine dimers in certain types of genes or necessary genes cause cell death. So, in Cockayne syndrome, the mutations in the excision repair nucleotide proteins work on active replicating genes, RNA and DNA. So, Cockayne syndrome kids can take care of all the defects, the pyrimidine dimers and resting genes. They can fix those easily. But they can't fix the ones that are actively undergoing synthesis or transcription. So this is a transcription excision repair defect. So if you can't fix the ones that are necessary at the time to make the cell grow, survive, do whatever it's trying to do, then the cell is going to die. So therefore, you don't retain cells with abnormal DNA, these pyrimidine dimers, because when you do get abnormal pyrimidine dimers that can't be dealt with, the cell dies. And that's the key. You have an absence of cancer in CS patients because the cells, when they get irradiated, if they have a pyrimidine dimer in a non-essential at that time gene, then it's going to get fixed with one of the other mechanisms. But if they have a mutation in a somewhat essential gene at that time, then you can't proceed with making that gene, and then you die. Now that's important because XP has a cancer risk, and a high one, a very high one. And that's because XP can't fix the genes either that are active or the ones that obtain defects or pyrimidine dimers at a resting state too. So then when the cell divides and continues on, it will carry forward in part some of that mutagenesis, if you will. Does that kind of make sense? I'll let you think about that for a second. Also read here. Some people might be able to comprehend larger words. I am unfortunately not one of those people, so I have to explain it in that way. But basically what happens is Cockayne syndrome is a mutation in transcription excision repair, specifically, while a XP syndrome is a mutation in global excision repair, and the mutation in global excision repair carries with it a cancer risk, basically. If you want to memorize it, that's kind of what goes on. So key features here with Cockayne syndrome, it's okay. And I don't mean, and this goes with any genoderm lecture, I don't mean to be rude when I describe these. Often these descriptions are taken out of text and literature. So I'm not even the one that describes them or makes them. So, I'm not trying to be offensive, but I got this from someone in a textbook or in a paper somewhere used Mickey Mouse as a descriptor. So, or mouse-like, as a descriptor. So that's why I'm using it. Anyhow, you're going to notice photosensitive eruptions with erythema and scale. Subcutaneous fat loss noticed around the eyes, as well as an aged appearance. Dwarf appearance, microcephaly, thin nose, large ears, somewhat longer limbs with joint contractures, large cold hands. As you'll notice that there's nervous system involvement, so diffuse demyelination. sensory neural deafness, salt and pepper retinal pigment, myotic pupils, so difficult to dilate, cataracts, optic atrophy, dental caries. And the one way I kind of remember this is I remember the South Park, specifically the South Park Mickey Mouse, because the South Park Mickey Mouse, has kind of an annoying voice, like he can't hear himself, deafness, is black and white, so that gives you the salt and pepper retinal pigment. Usually in South Park, the whites of their eyes is larger than the black part of their eyes, the pupils, and that gives you the myotic-like effect. The South Park characters are disproportionate. They're often shorter, and their arms and legs are longer than their torso or their trunk, proportionally. So that helps clue me in on that. And Mickey Mouse is a child cartoon, and a child cartoon, I think of children liking candy. Candy leads to dental caries. Lots of stretches here. Yeah, the only thing I don't quite think of is, and the reason why I use the South Park Mickey Mouse is, the South Park Mickey Mouse is kind of screwed up. He's a pretty aggressive guy, so therefore he most likely has some nervous system involvement, some nervous system deterioration, neurologic deterioration leading to intracranial calcifications. It's a stretch, guys. Any way that you can try to remember these is, your way. Oh, also in my Mickey Mouse mnemonic, we look at this and we say large, cold hands and feet, which Mickey Mouse with the gloves and the large cartoon feet fits that description. So use it if you like it. If you don't, that's totally fine. I'm not offended. Your management of this condition is through thorough sun protection, as well as referral out to the specialists that are needed based on the sequelae. There is no increased risk of skin cancer. I think I beat that to near death. And the support group here, there's a very good support group, cocainesyndrome.org, in case you want any more information, or maybe even like just for if you have a patient and you want to know where to refer them to. That's a good support website as well. Yeah. Moving on to TTD, trichothiodystrophy, also known as PIBIDS, is an autosomal recessive condition. PIBIDS is a mnemonic that's used to help remember this. The mutation is in the XPD family of genes, XPD being a part of the DNA repair defect pathway, excision repair genes. So there's XPD, which is ERCC2, XPB, which is ERCC3. How do you remember that ERCC3 is B? Well, the 3 in that gene looks like an unfinished B. That's basically how I remember it. And then 2 is, good luck. And then also note, when we're trying to make these diagnoses, we don't have to do anything fancy anymore. It is going to be DNA analysis when you note something may be concerning. There is a XP-like manifestation, so there's some overlap with cocaine, there's some overlap with XP, so just, a heads up in that regard. Mostly overlap with XP, but just wanted to bring that to your attention. We'll talk about that a little bit later as well. All right, and within the skin, we have photosensitivity in 50% of cases without signs of chronic actinic damage and no increase in skin cancer. Ichthyosis is noted, but isn't always present, as well as, you'll see that in TTD-NP specifically. Hair here, it's in the name tricho, so there's going to be some hair findings, as well as short, sparse, brittle scalp, eyebrows, and eyelash hair, and the tiger tail appearance under trichoscopy, or a polarizing microscope. Central nervous system is involved. Eyes, photosensitivity, cataracts are involved. GI and GU, decreased fertility and hypogonadism. MSK, short stature, facial dysmorphisms also noted as well. Key thing here also, hypogammaglobulinemia is noted. Therefore, there is an increased risk of infections with this as well. So if you're thinking of Bloom syndrome, that's great. IgA and IgM. This condition, just generalized hypogammaglobulinemia, gives you your recurring infection risk. Here's a good example of that tiger tail, finding under looking at your hair under a microscope, and an example of some of the more chronic actinic damage, as well as the hair findings on the right. All right, XP. probably the biggest bang for your buck in this chapter is XP. It's a genetically heterogeneous autosomal recessive disorder caused by defective nucleotide excision repair or error-free bypass of UV-induced DNA damage. The condition is characterized by increased sensitivity to sunlight. Individuals with XP are at higher risk of developing carcinomas, significantly higher. And then there is a notable phenotype that's a little more severe, DeSantis Cashion syndrome. Draw your own, ways to remember that. I'm sure you can come up with a few. The mutation is associated with, or at least looks similar to Cockayne syndrome in some capacity. So you'll see some overlapping features there. Findings here, the one big one that I want to point out to you, just even from clinical experience here, is your lentiginous. Now having seen a couple of these patients myself, lentiginous are noted in areas they shouldn't ever be, adult or child, and that can be areas like the ear, the the eyelids, maybe upper scalp or early scalp, findings like that. That you shouldn't have lentiginous there. You shouldn't be a 3-year-old with lentiginous anywhere. But if you were to have lentiginous, they definitely shouldn't be in these places. Areas that are not even really sun exposed, can also develop these lentiginous. You'll also see hypopigmented macules on hands, feet, face, and other sun-exposed areas. You'll see signs of actinic damage. Their skin cancer risk, you're guaranteed them pretty much. So unless you're really strict about your protection, so that includes basal cell carcinoma, melanoma. Your lifespan's about 37 years if you're watched pretty closely. XP, Western Europe, not that common. In Japan, more common, surprisingly, and then 1 in 250,000 in the U.S. Findings for that severe phenotype, the DeSantis Cashion syndrome, that is microcephaly, progressive neural decline, delayed growth in sexual development, deafness, and quadriparesis. So it kind of sounds Cockayne-y, a little bit. There's some Cockayne syndrome things there. Going into the genes a little bit, this is hard to memorize, so just, do what you can. But here are the different genes that are described: autosomal recessive in XP. So XPA is in DNA binding 1. XPB is in excision repair CC3. XPC is that's supposed to be endonucleus. Excuse me. So just like XPG, XPC is endonucleus. XPD is ERCC2. XPE is DDB2. XPF ERCC4. And then some key things to kind of look at. So XPB, XPD, XPG can have a Cockayne overlap. So what does that mean? It doesn't mean it's Cockayne syndrome, but it does mean that you can have both skin cancers, lentiginous, as well as the retinal degeneration, basal ganglia calcifications, etc. XPB, XPD has overlap with trichothiodystrophy. So you can kind of think of like maybe a rhyming game with that. Yeah. Management of XP here is, you pretty much understand that there's going to be a high incidence of skin cancer, as well as the stringent, most, necessary photo protection in the world. Tons of sunscreen, tons of, protective clothing. And there is a good website here, xps.org, which can help patients as well. And then moving on to Hartnup disease here. Hartnup disease is an autosomal recessive condition with a genetic defect on the gene in chromosome 5, but more importantly, the gene's name is SLC6A19. And that leads to a defect in a neutral amino acid transporter in the gut and the renal system. So therefore, you're going to not be able to absorb tryptophan. You're going to decrease your vitamin B3 production because tryptophan produces niacin, or like your body can convert tryptophan to niacin. So therefore, you're more likely to get a Plager-like syndrome, like dermatitis, dementia, diarrhea, and death is the fourth T not mentioned here. You're going to have retained gastric neutral acids, amino acids, which can get broken down in the gut lumen to produce more harmful components that ends up being like CNS toxic. Urine screens can help test for massive amino aciduria and tryptophan derivatives and clue you into the diagnosis, but DNA analysis will help clinch it. Skin here, you're going to notice, obviously, photodistributed erythema with or without bullae. You'll also see that on the hands as well because these are photosensitive disorders. But the key is going to be, you might have the pellagra-like symptoms, and you also can see the central nervous symptoms as well. How do you manage it? Well, one key thing, and pretty much the only thing you need to do, is return back the niacin that's not being produced by your body. So you're just going to supplement the niacin. You're skipping the tryptophan step. So let's go over some review questions here. These will kind of help lock things in. So we got long, narrow face, prominent nose, small mandible, short stature. Notice I didn't say anything about retinal issues, cold hands, long arms. I didn't say anything about big ears. So get that one out of your mind. Look for some more clues. Photodistributed erythema and telangiectasias. Well, all right. All of these have that. Recurrent respiratory and GI infections, so decreased IgA and IgM. Now you know the answer. What's the answer? Bloom syndrome. So we talked about Bloom syndrome being REC-QL3. We talked about Rothman-Thompson being REC-QL4. And I mentioned briefly there's Werner or adult progeria, which is REC-QL2. I just wanted to bring that in here just so we're making these connections between lectures. And then also, what's the gene for progeria? Like normal progeria, not adult progeria. And that's laminae, just so you don't get those confused. All right, so now a patient presents with the following findings: sensory neural deafness, subcutaneous fat loss, noted in the face with sunken eyes, thin nose, large ears, large cold hands, Mishka Muska, Mickey Cockayne syndrome. So, why do CS patients have low rates of skin cancers despite having a mutation involved in the repair of UV-induced damage? And we harped on this, together as a family, and ultimately you're going to be able to tell me, well, the mutation inhibits transcription excision repair, which leads to cell death almost all the time, Austin. And in XP, it's a global excision repair that gets messed with. Therefore, some of the mutagenesis is retained in cells, leading to cancerous causes. And then I'll be proud of you, and a tear will stream down my face in just pure appreciation of your knowledge and development. All right. And now we have a patient presenting with the following findings: alopecia of the scalp, eyebrows, and eyelashes, dystrophic nails, short stature, small hands, feet, and hypoplastic thumbs. I know they might have had you in the first half, you weren't quite sure, and then I said the hypoplastic thumbs, so then now you're going to know it's Rothman Thompson, Rothmund Thompson. You can use the Rothman part to remember most of these things. So what's the R? Autosomal recessive, no radius for arm development. What's the O? The rare chance of osteosarcoma or other malignancies. What's the T? The telangiectasias. What's the H? Hypogonadism, hypothumbism. What's the M? MSK for being short. What's the A? Alopecia and acrokeratoses. So the squamous cell precursor in this case that they can develop into. What's the end? A nail dystrophy in a normal life. Here you got a patient with a alopecia, brittle hair, chronic actinic skin damage in no particular order, and hypogammaglobulinemia leading to recurrent nonspecific infections. Well, that's TTD, trichothiodystrophy. Which can be known as PIBIDs, and PIBIDs breaks down to photosensitivity, ichthyoses, brittle hair development, intellectual impairment, decreased fertility, and short stature. How about a young Japanese child with actinic damage, hypopigmented macules, and lentigines all over the place that she shouldn't otherwise have? That's XP. And those are your key findings: lentigines, actinic damage, and hypopigmented macules. And then do note, because it's coming up on tests more often now, there is a more severe phenotype, de Sanctis-Cachillon syndrome, which has microcephaly, progressive decline in intellectual capacity, delayed growth, as well as sexual development, deafness, and quadriparesis. And then in hardened-up disease, I feel like we just talked about it, there is a SLC6A19, which is a neutral amino acid transporter deficiency. Therefore, you do not bring in tryptophan. Tryptophan does not get converted into niacin. And then you have the pellagra triad of dermatitis, diarrhea, dementia, and maybe even death. And therefore, when the tryptophan is broken down in the gut lumen further, you have toxic CNS, proteins or molecules, and they lead to ataxia and tremors. Big shout out to student Dr. Eschbaugh, student Dr. Jacoby. Could not do this without them. Give them a thank you down below. Remember, if you have any way to remember these, or if you see something that doesn't quite fit, put it down in the comments. Let me know. Let us know. That's how we learn. And until next time.